Good morning, everyone. Today our guest speaker is Dr. Marielle Engelen, Associate Professor from the Department of Health and Kinesiology, A&M University. Dr. Engelen received her bachelor's degree in 1990 in Maastricht University in Netherlands, majoring in health science, and later her master's degree. Her master's degree covering two different majors. One is in health policy and administration in health education, and the other is in movement science. After her master's, Dr. Engelen worked as a research associate in the Harvard UC Area Medical Center, California, and later in Maastricht University until 1995. She finished her PhD in 2000 in the Department of Respiratory Medicine, also at Maastricht University, with her dissertation entitled Muscle Wasting in Chronic Obstructive Pulmonary Disease of Metabolism and Functional Perspective. Later, Dr. Engelen worked in Maastricht University as an assistant professor until 2006. She then went to the University of Arkansas for medical science and worked there from 2007 to 2012. Dr. Engelen joined Texas A&M in 2012 and is currently a tenured associate professor and co-director Center for Translational Research on Aging and Longevity. By last year, Dr. Engelen has published over 15 peer-reviewed papers and presented her research over 38 times as invited speaker at both international and national conferences and symposia. Since 1997, Dr. Engelen has received over 18 funding projects covering research areas from the effects of nutrients and exercise, disease, and the relative treatment on energy, muscle metabolism, with a special focus on amino acid, to her current research interest on metabolic effects of clinical treatments and nutritional interventions. Today, she will give us a presentation on protein is a very important but undervalued micronutrient in the nutritional care of patients with cystic fibrosis. Please join me and welcome Dr. Marielle Engelen.
Okay, thank you very much for this very nice introduction. As you already told, the title of our presentation is Why Proteins Are So Important in Cystic Fibrosis. Well, when you look at the title, you think, well, that's obvious. When you have a disease in which malnutrition is so common, protein intake is important, but unfortunately, this is not in common and generally accepted in cystic fibrosis. So when we moved from Maastricht University to UAMS in Little Rock, we were very surprised that that there was no research done looking more at the fact of muscle wasting and COPD and the underlying disturbances in protein metabolism, particularly because I've worked my whole life in the field of COPD, chronic obstructive pulmonary disease, which is another chronic wasting disease, in which it's so clear and obvious that you need muscles for survival, you need muscles for quality of life, and protein are so important. So we started our research line in Arkansas because there are two big CF centers, one pediatric CF center as well as an adult CF center. And I'll show you some data of our research. First of all, what is CF? CF is a life-threatening inherited disease that affects multiple organs. It affects the lung. The lung and respiratory failure is, in most of the patients, a major cause of death. It affects the intestine. It affects the liver because of a pancreatic insufficiency, and it's mainly in Caucasian, present in the Caucasian population. So as you can see, 30,000 people in North America suffer from this disease, and 35,000 people throughout Europe. And large populations, particularly present in Western Europe as well as in Ireland. The symbol for cystic fibrosis is the blooming rose. And why the blooming rose is because it started actually in the 60s, that a young kid, because it's a disease that mainly affects children, adolescents, and the younger adults, because it's very difficult to pronounce. And that's the reason why one little kid was listening to his mother on the phone and heard her talking about something. And he said, after the phone call, he said, okay, you're always talking about cystic fibrosis. So that's an easier way of saying cystic fibrosis for the kids. So cystic fibrosis is a defect in the CF transmembrane conductance gene, and which is involved in the regulation of salt and fluid, and has a particular role in the loss of chloride transport. And as a consequence of this defect, you see that there's a lot of mucus built up in several organs, like the lung, the pancreas, and the intestines, which are the cause of the problems. As I mentioned, CF patients are characterized with a severe defect in the lung function due to a thick mucus accumulation in the lung. And this mucus actually is a source of the chronic infection, the low-grade infection, but also the source of the respiratory infection that often occurs and defined as exacerbation. And these infections in the lung leads to progressive and irreversible lung damage. Another organ which is mainly affected is the pancreas. And because there's also mucus built up, which leads to maldigestion of fat and protein. And these patients, 80 to 90% of the patients are dependent on pancreatic enzyme therapy because of the atrophy and often the insufficiency of the pancreas. The CF disease consists of severe as well as mild, dependent on the genetic mutations. So the severe disease, when the patients have a severe disease, they are characterized by both the pancreatic insufficiency, so they're dependent on pancreatic enzyme replacement therapy, as well they have often severe deterioration of lung function. And of course, their life expectancy is reduced. On the other side, there are also patients who have more the milder disease, who are pancreatic sufficient and have a milder lung disease, and they live in general longer. And when you look at, for example, the projected survival curves for children born in 2010, you see that the median life expectancy is 40 years right now, which already has substantially improved compared to 2 decades in which it was around 10, 12 years old. But still, there's a long way to go. And the survival, of course, is also dependent on what I mentioned just recently about the genetic mutation they have. So when we came in Arkansas, the first thing we were interested, okay, let's look in a large group of CF pediatric children, what their changes are in the body composition. So we studied 80 patients between 8 and 18 years old and looked at the prevalence of malnutrition and the prevalence of muscle loss. And as you can see in this figure, we made several body weight categories containing of 10 percentile categories. And as you can see, for example, here, in this group of patients, already 40% of the CF kids were depleted. So even patients with according to CF Foundation, a recommended body mass index, already 30% were malnourished. When you look at this, you see that therefore 65% were underweight in one form or the other, and 26% were severe underweight. So what are the causes? Of course, there are multiple causes influencing, affecting malnutrition in CF. Of course, the lung problems, which results in increased energy expenditure because of the increased work of breathing, the inflammation that's present in the lung, and the exacerbation. The other one, what I already mentioned, is the GI problems because of the maldigestion of the proteins and fat. Often they don't feel well, they are nauseous, they have, because of the GI problems, their intake is reduced, the appetite is reduced, and of course they also have hormonal changes. So all these factors influence one way or the other the body composition and the body weight of these patients. And the fact is, when you look, for example, this is a study done in 2013, also recently, and when you stratify the patients upon underweight, severe underweight, as well as mild, moderate, and normal weight, you can see that it affects height, the height of these kids. So already at an early age, when they are underweight, it really affects their height. The same with lung function. When you already have a reduced body weight at a low age, at a young age, I mean, you have a longer lung function, and that will stay low, and also this reduction in time will be present. Seeing that already there's an impact of early childhood malnutrition in these patients. And also in our study, we found that, for example, when you look at the lung function of the patient with a normal body weight, it is around 90%, but it gradually reduces when body mass index goes down. And the same was also with bone mineral loss. These patients, the general age was 14. You can see that even patients with a normal body mass index already had almost 20% had a low bone mineral density. And when you go even down to the patient with a low body weight, you see that between 40 and 50% of these patients had severe bone mineral loss. Also effect on survival. You can see that the patients with who are really low body weight have a worse survival. So 80% of the patients are surviving at the age of 20. But however, what I mentioned, I mean, body mass index doesn't say everything, because when you, for example, measure fat-free mass by the DEXA scan and you plot it against the body mass index, you see a large scatter plot. You see a relation, but still it's widely scattered, indicating that also when you look at the body mass index, these are for adults, and you say, okay, above 20, it's normal. You see that still a substantial group of patients have loss of muscle mass despite a normal body weight. And that's what we also found in our children with CF. Even with the normal body mass index or maybe slightly reduced, you see a severe muscle wasting. And the muscle wasting was characterized as fat-free mass index less than 5th percentile, so that's severe muscle loss, indicating that low muscle mass values have been found in not only in CF adults, but it's already present in children with CF, despite normal or even elevated body mass index. And that's what we also saw. For example, when you stratify then based upon muscle mass, you see that bone loss is present not only in the whole body, but it affects the spine and the hip. And the same also for lung function, you see a reduction of muscle mass. And also when you specifically look at these patients, you see that they have lower muscle strength, arms, legs, but also the inspiratory muscles, which is important for them for breathing, and also during an exacerbation. But also we saw that these patients with low muscle mass were characterized by a higher number of hospital visits in the preceding year, and also a higher number of exacerbations in the past year, indicating that they are also much more vulnerable to become severely ill when they already have this disease. And in this study in 2013, you see that all these studies are quite recent. This study was done in the patients who underwent a lung transplantation, and they looked at both body weight as well as muscle mass, and looked at what the percentage of these patients were underweight or had loss of muscle mass. And this group of patients, for example, died before the lung transplantation, because when the lung function is going down, the only option for these patients, and when the lung function is that low, is to receive a lung transplantation. But even in this condition, you see how important it is to have an optimal nutritional status. Because when you see the patients who died before lung transplantation, 65% had a low body mass index, but even almost 75 to 80% had loss of fat-free mass. And even when they died just after lung transplantation, 40% had a low body mass index, but even 6% had a lower fat-free mass, indicating that still you have patients with a normal body weight but with muscle loss. And even after, when they survive the lung transplantation, malnutrition is present in these patients. And as a kind of summary of this part, so muscle mass is important because it has an effect of so many factors, not only survival, lung function, which is generally known, but also on more clinical variables like hospital stay, exacerbation, and so on. And of course, very important is the quality of life. So what are the recommendations right now? As I mentioned before, I mean, there's a lot of focus in the CF world on caloric intake, high caloric intake. There's a lot of focus on high fat intake, although, the recommendations with respect to protein are hardly there. The only thing that's available right now is a general recommendation. Okay, the energy needs to be at least 120%, but could extend over the 150. I mean, everybody agrees on that. Protein, they say about 120, but no studies have been done to actually study that. But we think that these recommendations are much more higher based upon other studies and other chronic wasting disease with inflammation present and so on. Because there are a couple of factors that actually affect this protein recommendation, like the work of breathing, the inflammation, but also the exacerbation, which really increases the protein need. But there are also other factors which are important. For example, the degree of protein digestion, because you can provide patient proteins, but when it's not digestion, it's not coming into the system, so it cannot contribute to muscle anabolism, to muscle growth. And also, of course, to what extent the pancreatic enzymes they take together with the meal are actually working and increase the digestibility of the protein. Very simple questions, but not always very easy to study. So what we did, so in the first study, what already mentioned, okay, looking more at the prevalence of muscle wasting and the effects on clinical status. But now we are more interested in, okay, what are the factors influencing muscle wasting? Because we know that there are GI problems causing the reduced digestibility, but to what extent actually is protein digestion impaired? We do not know that. But on the other side, the other studies were, okay, when we give them protein and when they are easily digested, will it actually induce muscle gain? And this is important because often in other chronic wasting diseases, it's suggested that there is a kind of anabolic resistance. And the third of the fourth research study we were doing was, okay, maybe there are underlying intrinsic disturbances in protein metabolism, which is also affecting the muscle. But let's first focus on the number 2, the protein digestion problem. As I mentioned before, pancreatic insufficiency is present in 9% of patients with CF. It impairs the digestion of fat and proteins, but the focus has mainly be on the fat. There's quite a variation in the studies, because most of the studies performed were 3 to 5 day fat balance studies. You see quite a variation in the fat malabsorption, between 70 and 80%. Nitrogen balance studies are not accurate at all, because when you take protein and when you measure the output in the colon, I mean part of the output, part of the proteins is used by bacteria again, so it's not a very accurate measurement. So what we wanted to do is actually establish or develop a new method in which we can actually measure protein and fat digestion in CF, but also to see to what extent the pancreatic enzymes actually can restore this impairment. So to briefly say that we use stable isotopes. And with stable isotope, you can actually measure metabolism without affecting metabolism. So normally in a meal, you have protein and you have amino acids. And proteins are in the gut with protease digested and free amino acids are produced. Of course, the free amino acids are not converted and can be measured in the blood. So the ratio between the amino acids coming from the protein as amino acids coming from the free amino acids in the meal gives a kind of ratio, the digestion ratio. And that's also what we have done, for example, with 2 stable isotopes, spirulina, so there's a labeled protein, and phenylalanine, which are labeled free amino acid. The spirulina will be converted to phenylalanine. And by calculating a ratio coming from spirulina as from the free amino acid, it gives you a reflection of the digestion problems in CF. So the higher, so when you have a ratio of 100%, all the protein is digested into free amino acid. When this ratio is going down, it means that there's a digestion problem. So we did a study in 19 patients with CF. This is a complete study. I will only focus on this part of the study, in which these patients were studied during 8 hours. They got sip feeding, small sips of nutrition, to which the isotopes were mixed. And after 2 hours of intake, we gave them the pancreatic enzymes. So for the nutrition, we used the Ensure Plus, because that's a nutrition that's often used in CF. And pancreatic enzyme, the amount of pancreatic enzyme, like is done in CF world, it's based upon the fat intake. So the fat intake in the Ensure determines how much pancreatic enzymes we gave. And we did blood sampling throughout the study. So in this group, we had 10 pediatric patients, 9 CF adults, and a group of healthy controls. Kids were 15 years old, the adults 29, and the healthy older adults 2. This figure shows you the data. So this is the time scale. This is just, so all the healthy controls also got the sip feeding every 20 minutes of the Ensure. The CF patients also got the sip feeding every 20 minutes during 6 hours. But after 2 hours into feeding, they got a pancreatic enzyme. And as you can see here, the ratio, the ratio between the protein, phenylalanine coming from the protein and phenylalanine coming from the free amino acids, was half of the digestibility in the healthy control group. So the digestion impairment was 50%. When you look at the moment you take the pancreatic enzymes, you see this digestibility increase slowly, but after almost 2 hours, it reached the maximal value, and then it slowly reduces, indicating that it takes time before these pancreatic enzymes actually can work in these patients. And it's almost normalizes the protein digestion, but it's not really, and then it reduces again. When you stratify between the CF adults and the kids, you see exactly the same pattern. And the fact that it takes time for it to work suggests that you really also need to take slowly release protein that takes time before it actually enters the circulation. And this was quite a surprising finding, particularly the time issue. So it's not only important what kind of proteins you take that are easily digested, that are more slow. On the other side, you can also think, okay, maybe we have to adjust the pancreatic enzyme therapy and look specifically at the enzymes we are giving and see how can we optimize them for the protease activity. Because what I mentioned right now, the enzyme therapy is mainly based upon the lipase, but now it's also important to look at, when you look at study protein metabolism, that it's also effective for your protein intake. So there's still a lot of work to do in this field. But we have now a tool in which that we can use when we want to compare, for example, different proteins or different enzyme therapies. So the next step was, okay, are these patients actually able to respond normally to proteins when you give them? Well, when you look to other chronic wasting diseases like COPD or also cancer, expert group recommend a very high protein intake of 1.5 or even more in conditions of high inflammation. which is much more than actually currently recommended in CF. And interesting, this is a study that was done already a while ago, but it provides very interesting data. They studied a group of CF kids, and they gave different levels of proteins and looked to what extent this level of protein induces protein anabolism. And as you can see, you know, when you give 1.5, they are anabolic. But when you give more, 3, they are more anabolic. And even when you give very high levels of protein, they even respond even more anabolic. It indicates, okay, you can induce protein anabolism in these patients. But, you know, to give 5 grams of protein per kilogram body weight, you know, it's a lot. And the problem is, you know, that it's because of the reduced protein digestibility. Because when you give so much protein and only a part is actually digested, you know, it will increase the load of this undigested protein, which is not great and is actually sometimes harmful. So it's very important in these patients to give not only high level of proteins or just the optimal amount of protein, but that the composition needs to be correct and also that the digestibility of these proteins is optimal. Or that you use enzymes that can actually help with the digestion of these proteins. So one way to circumvent the reduced digestibility is actually provide them free amino acids. Because free amino acids, you know, they don't need to be digested, but you take them, they immediately arrive in the circulation, so you don't have the problem of digestibility again. So we were interested to see whether, okay, when you give them a certain amino acid, free amino acids, do they respond anabolic? And particularly when you take the best part out of the free amino acids, if they even respond even more anabolic. And these essential amino acids, that's known already and also in other diseases like cancer, but also in healthy older adults, that, you know, these are the amino acids that directly stimulates muscle growth, are stimulating muscle anabolism. So when you only take this part out of a protein, I mean, that will achieve the same response than when you give all the free amino acids. So you only need that part of the protein. So we were interested to see, okay, is this also the case in a patient with CF? So we did the study in a pediatric CF patient. They were admitted to the hospital for an exacerbation. The reason why we studied them during the hospital stay is more because of practical reasons. Patients were there. They already had a line in place for blood sampling. And because we wanted to compare essential with the total amino acid mixture, we want to study them back to back, 2 subsequent days. So we only were, it was required to put 1 line in place, and we could keep that line open for 2 days. So these patients we studied, and they were just laying in bed in the morning, just watching television. So we infused the isotopes with this, and we took some blood samples from the hand. And after 3 hours, we gave them the drink with essential amino acids or the total amino acids, just to compare, okay, are these patients also responding anabolic to the essential amino acids? So we had a group of 15 patients, and 7 patients were severe nutritional, severe malnourished. So they had a reduced fat-free mass as well as a reduced body mass index. As you can see, also the lung function was reduced in the patients. And we compared those with a group of patients with a relatively with no nutritional failure. And as you can see, the essential amino acid mixture induced a much more higher level of protein anabolism compared to the balanced mixture of amino acids that you normally can find in a whey protein. And also on an individual level, you can see for each patient, it was plotted the balanced mixture of amino acids and the essential, and you see an all increase after intake of the essential. And that was both present in the patient without nutritional failure as well as the patient with nutritional failure, indicating that essential amino acids work in these patients. And also this is differently plotted. These are the balanced mixture and the essential amino acid. So when you give the essential the amino acids, you can see that that anabolic response is steeper in the patient after intake of the essential amino acids. However, when you compare both and you only look at the amount of essential in both of the mixtures, you see that they are perfectly on one line. These are the total, these are the essential. So even in the balanced mixture, the essential amino acids are the most important amino acids in the meal that leads to anabolism. So, and this is perfectly in line with what we found in cancer as well as CP. So patients respond to free amino acids, and particularly the essential amino acids. So, so anabolic resistance to the essential is not present in CF, and even not when they are very malnourished. Indicating, okay, we can measure now the digestibility, so we can have to adjust the protein or the pancreatic enzyme. We can do that because we can now actually measure the digestibility. We know that they are responsive to proteins, particularly the certain amino acids. But what are other factors like changes in protein metabolism? To what extent are these present in CF patients that can affect muscle wasting? I don't go into detail because this is too complicated, but we were also interested in certain specific amino acids because, as I mentioned, protein consists of amino acids. And one of the amino acids which is very important in CF is arginine, because arginine is a precursor of nitric oxide. And nitric oxide is important not only for immune response, but also for in the lung. And often reduced arginine levels are found in the lung of patients with CF. So we are interested because arginine is produced not only from dietary intake, but also from protein breakdown here. And also from protein breakdown over here, because when you break down muscle, glutamine is produced, and via this pathway also arginine is produced. So you can imagine when you have a kind of deficiency in the arginine pathway, it will also upregulate this pathway and probably also induce muscle breakdown. So indicating that protein metabolism is not only important directly for net anabolism, but also it can be changed because of a deficiency of other amino acids like arginine or leucine. And indeed, we found in patients with nutritional failure, increased protein synthesis and increased protein breakdown, indicating an upregulation of protein turnover, which is important to, particularly in the situation when inflammation is present, because you need extra proteins from the muscle needed for acute phase protein synthesis. And indeed, in these patients with nutritional failure, you had a reduced arginine concentration, although it was still possible to produce enough NO. So indicating, I don't want to go into detail, indicating that, there are already disturbances in arginine concentration in these patients, but also in this whole metabolic pathway we also studied, and which affects protein metabolism, but also affects muscle protein breakdown, indicating that there are multiple pathways in which muscle loss can take place. And particularly we think that during an exacerbation, when the demand for arginine is so high, that this also can be a trigger of increased protein breakdown. So how to tackle when you look at, when you summarize based upon the presentation I just gave, you see that the quality of the protein is important. High essential amino acid is important. But maybe, we need more insight in specific amino acids which may become deficient in CF in the stable condition or maybe during exacerbation like arginine. So maybe we have more research need to be done to optimize that nutritional intake. We also know that we have to give very high levels of protein, and particularly more than 1 gram kilogram body weight. But of course, in order to give this, the protein needs to be easily digested. This is very important. So you need proteins with high essential, prefer also with other amino acids which are easily digested, and of course the pancreatic enzyme therapy that needs to be high for enzyme activity for proteins. Of course, exercise is very important. When you only give calories, you increase fat mass. You need exercise as an extra anabolic stimulus, because you get the most optimal effect of combining the optimal nutrition with the exercise. Particularly the resistance exercise is important. And of course, inflammation. Still, we need to find a way to reduce the inflammation. I'm not sure how much time I still have. I want to touch briefly about what's going on recently. I mean, I show you some data of the past few studies, 2013, 2014, in which we indeed, we see a shift in body mass index distribution over time in CF, which is fine, which is great. I mean, when you look, for example, before 1990, the average body mass index was 20. Between 2000 and 2011, it's already increased to 22, which is great. This is perfect. And also when you look, for example, at the percentage underweight patient was 20, it is reduced to 11, which is fine. And it has to do with, there's so much improvement with respect to treatment, with respect to nutrition. We also see that, one thing we also see is, for example, that the percentage of overweight of obese patients actually increase. And that's a little bit more disturbing news. And, not only that they're more obese, because in these obese and overweight patients, as I mentioned before, you still can have severe muscle loss in these patients. And as the sarcopenic obesity is actually even, the detrimental effect is even worse. So because you have a kind of resistance to exercise, resistant to extra negative factors influencing metabolism, when you have both increased fat mass, elevated fat mass, and at the same time muscle wasting. But most disturbing was that it was an increased central fatness in these patients, in these children actually with CF. And these children were also characterized by elevated cholesterol and LDL. And maybe it has to do with the fact that, or likely has to do with the fact that right now still the requirements are so based upon fat, calories, without looking at, what are the best fat sources. And actually in our study, we also found this pattern. In these children with a normal body weight, a recommended body mass index, we saw an elevated fat mass and very high. Although the fat-free mass was 100%, which was okay, we still had a very high fat mass. And then you think, okay, we know that, for example, in the patient with nutritional failure, when you increase body mass index, it has a positive effect on lung function. However, when you are already have a normal body mass index and you go to overweight or obese, you don't see that increase, that positive effect on lung function anymore. That is absent. And this was in adults, CF adults. I'm sorry, these were in CF children, but the same is also present in CF adults. As you can see, lung function goes up until the body mass index of around 22, 23, but afterwards there's no improvement of the lung function anymore. Still, this is the first step in the field of obesity and overweight. We also have to look more closely what we are doing now with our patients. The focus is on fat mass, but we have to look at more the better fats, but also look at proteins. And what I mentioned here, 2014, said, okay, it's particularly the consumption of the saturated fat, which is responsible for this central obesity. And this is also a figure published indicating that the saturated fat is very high and the unsaturated fat is relatively low. So although the fat intake is what they need, it's just the bad fat they are taking. So as a last slide, I think there's still a lot to do in this field. both in the patient with nutritional failure, with low muscle mass. I mean, there's more studies need to be. We have to already change our guidelines and more focus also on the protein, because protein is an important factor. And the fact that so many CF dietitian, when I was working in Little Rock, still wasn't aware that, you know, with a DEXA scan you can also measure muscle mass. I mean, that already says enough. You know, we have to we use the DEXA scan for measuring bone mineral density all the time, but at the same time you get the information about muscle mass, and we really have to look at it because it has such an important effect on their outcome. So still the information on the optimal protein amounts and the protein type is needed. So we are now establishing an other disease methodology to be able to measure what the protein and specific amino acid requirement is. We use stable isotopes for that, and I think we still have to optimize our methodology in order to provide us more information what's going on and how we can improve the health of these patients. Also, you know, we also have to be careful, and more studies need to be done about the recommendation of that high fat, high caloric. I mean, we have to fine tune that recommendation. So in general, that's my last statement. I mean, we need so much more. I mean, we've gone a certain direction, but right now we notice that although we have published in the past year several publications with respect to the importance of protein, and it's very difficult to change the general way of thinking from fat and energy to the importance of protein. And so there's still a long way to go in order to improve nutritional care in CF. Okay, thank you so much. Okay, are there questions?
So in one of your slides, and I think the take home, the summary before you talked about, before your last couple slides, you mentioned the protein recommendations in grams per kilo body weight.
Yeah.
And there were a few slides before that where it looked like the recommendation for what was prescribed in the study was grams per kilo fat-free mass for protein.
Yeah.
So which would, so in obesity, for example, I think grams per kilo of fat-free mass for our protein recommendation would be more appropriate for that group. But for this population, which way should the clinical field go in terms of protein recommendations?
Of course, you know, preferably you want to express per kilogram of fat per mass, but not everybody does have a DEXA scan or other ways to measure body composition. So then it gives you a general idea of, okay, let's go for the 1.5 gram per kilogram body weight, because that's a more general way. It's easy to calculate and it's easy to, because still, you know, when you look at it, I agree with what you say. I mean, because when you measure body weight, you still say, okay, so much, that is the percentage of body weight is muscle and that is fat. But, you know, you need protein for your muscle mass.
But which do you think would be better for this population? Because how much, if you, in certain instances, if you go for grams per kilo total body weight, you may be providing the patient more protein than grams per kilo fat-free mass, especially if the patient is protected. So
that's right. That's right. Because that's also when you look at the. That's also if you want to
How much fat-free mass does this generally this population have? You know what I mean? And you don't want to cut them out on protein because you're going by fat-free mass. So I'm just wondering which way you think would be better, or should it be an individualized approach?
The best would be an individualized approach, that you actually measure the amount of muscle mass and based upon that. Because when you look, for example, at that plot in which we plotted the intake versus the net anabolism, the patient with all patients got the same amount of essential amino acid, but the patient with muscle mass loss, they were at the highest part of that line because they're relatively per kilogram of fat for mass, they got more, indicating that, you know, if you want to have a more optimal approach, you should do it per kilogram fat for mass. And that's the same, for example, when you only look at body weight, and you have patients with sarcopenic obesity, hidden weight loss, hidden fat-free mass loss. I mean, they got relatively, that's not optimal for them either. So the best thing is actually to measure the fat-free mass, but it's not always available. I mean, there's still a discussion about, okay, DEXA is a wonderful method, but it's also costly. It's not so easy to be done just in a clinic. Now we are doing studies in which you compare more and easy to use body composition analysis, like the kind of scale which you can measure with the bioelectro impedance to immediately give a reflection of fat mass. But definitely we have to go there, because also when we want to provide treatment to this patient, in order to be able to see whether it's working, you have to measure muscle mass and not only body weight. So, yeah. Okay. Yes.
So in the slide with the arginine, so are you saying that supplementing arginine could decrease muscle wasting?
Well, we are not that far. I mean, we know, for example, in our studies in sepsis, that these patients, they are at the intensive care unit. They have high inflammation. They are arginine sufficient, and in those studies, we've seen that when we provide them arginine, in this case it was IV, that you can actually reduce protein breakdown. So it is a potential mechanism.
So would then citrulline supplementation maybe have similar effects?
Yeah, the reason why I put citrulline is because the taste of arginine is horrible. So citrulline is a better amino acid, but still you want to put citrulline as part of mixed with protein, because you need also the other amino acid, but with a higher citrulline level. But we have to do more research, or particularly, for example, during exacerbation, which we think that the need for arginine is just much higher, and then we can also see the link with protein metabolism. But with other disease, and that's the reason why it's so important to always compare disease also with other disease, because you can learn so much about how metabolism works, and also the effect of protein or amino acid intake works.
So, from your most recent findings and some of the most recent data that you presented, have these findings made an impact or a change with Abbott or Nestle in terms of the composition of proteins specifically geared towards cystic fibrosis patients?
No, well, actually, right now it's still difficult. I mean, we were recently we were invited to write a review on what is the state of the art right now, what is the knowledge available recently about CF and protein metabolism. But to change the general practice is difficult. And although, and very interesting, because a few months ago, we gave a presentation to CF parents of CF kids. And they were so desperate about just getting knowledge. What can we do in order? Because they know that just providing them fat or is not working. So even the parents say, okay, we need more information. So they were very helpful, but still to change the world, and also to change, even we spoke to Abbott and say, okay, maybe we should do a study comparing enzymes or different nutritional supplements. They're always so cautious. So it takes time, even more data from our side, because there are not many groups in the world who are doing protein research in CF. But it's not easy to change a way of practice that's already ongoing for such a long time, even with the industry. Although there is, I think there's enough money available and with CF research, but the only thing we are now lacking here is a CF center. So we need CF patients also here, because that's the problem, of course, right now we are facing, is that the CF patients always go to a CF clinic, accredited clinic, and that's not here in College Station, but in Texas, or in Houston, or in Temple. Yeah, still a long way to go, but I mean, these studies are so easily translated also for other chronic diseases. So I mean, there needs to be some moment that say, okay, we have to change the practice here. But it takes time, and it takes effort, and it takes money to convince people that we have to go a little bit different direction. And which also exercise is important, and not only just keep them busy, particularly give them a resistant exercise, focusing on the muscle instead of just looking at their body weight. Yeah. Yes.
Have you looked at all into utilizing deuterium methods instead of stable isotope methods for measuring proteins and cystic breakdown?
Well, right now with our isotopes, why would we? I mean, we're also using deuterium, but more in relation to fat metabolism. With our isotopes, maybe specifically looking at protein metabolism, the methodology we are using right now, and we actually have fine-tuned it, because the studies we showed right now in these data is we use a continuous infusion of isotopes. Now with our data, in which you just give a pulse, we get beautiful data of all different amino acid patterns at the same time, with only having access to one line. So yeah, of course, in the future, the deuterium is very interesting, particularly also looking at fat metabolism, because now what you want to do is, okay, do you have a stable isotope panel which gives at the same time information about protein metabolism, but also changes in fat metabolism, and see how CF patients respond to nutritional intervention. So then we can use both methodology. But right now for protein, I think with our new pulse method, I think we already are. Because, these are younger individuals, and particularly the kids, you don't want to stick them too much or whatever. And with the deuterium, it takes time. It's still a possibility. So dependent upon the research question you want to tackle, you see what kind of methodology works best.
I guess part of the reason that I'm asking is deuterium allows you to look at muscle protein synthesis and breakdown over longer periods of time, which may be beneficial. I mean,
sure, but how do you want to measure it? Then you still have to take a muscle biopsy. Right now we try to be less invasive as possible, but absolutely, it can give you a better insight over a longer period of time. But it's dependent on what your research question is, and if you can measure it acutely to see whether something is anabolic, that's the first step. And then in the long way, you can say, okay, will it affect? But then you can also look look at muscle mass itself, of course, as the endpoint instead of FSR. But you try to be less invasive as possible, particularly in these kids.
In your initial feelings, the individuals, did they just come in at a regular state, or were they fasted?
These were fasted, yeah. So we measured actually that study in which we studied adults at UMS in the medical center, and children in the Oxford Children's Hospital. Also, these children were studied when they are at the end of the exacerbation, because they were already laying there, and you always want, when you do human research, the most difficult part is recruitment of your subjects. So you want to make it as convenient as possible, and also combine it with a clinic visit, because they already have to go to see a doctor so often. So you really want to reduce the burden on these patients. Yeah, but they were in the fasted state.
Could you, or would you attribute any of the time it takes, the time you got to the fact that they were fasted, or why not have them come in at a normal state? Because that would be the end goal, to see.
Well, they were fasted, but at that moment we gave them the Ensure. So that was our nutritional nutrition we gave them in a standardized way, so that we could measure. I mean, this was kind of a methodology development. Right now we are doing studies in which we just give the nutrition as a bolus, like general food intake is also not a sip feeding, but just as a bolus. But that way we just gave it as a kind of continuous feeding pattern, just for model development. But also, a lot of patients actually get overnight feeding continuously, so it's comparable to that. Yes.
I have two questions. The first one is, I'm curious, what kind of food the patient with CF used to consume to get fat intake? I think it's 40%.
Yeah, 45% in general is a recommended fat.
What kind of exercise is recommended for them because of the breathing problems?
Yeah, no, maybe I can ask Dr. Cannon, she's a CF physician, what is in general the recommended, or in nutritional care? You say, okay, as fat intake as high as possible, get whatever you want if you reach that energy intake, or are the specific recommendation right now in the care of CF patients?
So often, developmentally, it depends on the age of the patient. I'm a pediatrician, so when you get to, for example, a toddler who's going to be grazing anyway, it's difficult to get anything out of them. then it really is whatever they will eat and butter everything. And that's often the fat that gets into the diet is simply buttering every vegetable and lots of pizza and things that you wouldn't necessarily hand to a child because they would be clamoring for it anyway. But that's based on a piece of data that I think folks probably didn't necessarily get a clear idea. The reason that there's such focus on fat is that that is what is clearly coming out of the patient when they malabsorb. And if you know the smell of rancid fat, you know when a CF patient is malabsorbing from across the house. And that's really what he's focused on the fat to begin with, is that there's a silent protein malabsorption. The parents don't recognize that, and the clinicians ask about fat malabsorption because you can see it. It skims on the top of the toilet water. You can smell it, and you know that that's happening. And you know that they have an energy deficit at the cellular level. They have an increased energy requirement. And the easiest way to get that in from a volume standpoint is fat. And that's also the reason that it's been the primary focus, is it's harder to get high protein content meals into young children without butter or some other fat component that makes it much more palatable. The other issue is that by the time a CF patient has infection, one of the primary infections outside of the lung are the sinuses. They can't smell anything. So food is not appealing in general. And trying to get someone to eat can be a real problem, which is why we frequently move to putting in gastroscopy tubes and doing it that way in order to try to get rid of the power struggle that ensues between parents and children trying to get them to eat. And then once you get to the teenage years, there's a whole set of primarily females that are happy to not take their enzyme so they can easily participate in looking like the models that aren't a good body image to begin with. So there are a whole host of problems. And so fat is the wrong answer as the only answer, but there are reasons why that was the first answer. And I think training people to think about protein really won't be that difficult. The data will speak for itself. I mean, people want to make it right from the clinical standpoint. It's just a matter then of trying to get it into the patient, how to do that. So one of the things that we do clinically when we have protected individuals coming into the hospital is put them on TPN minus the fat, and have been able to get a nice anabolic response in individuals that otherwise were in really serious condition, such that they could then begin a pulmonary rehab exercise program that they couldn't participate in prior because they just didn't have the muscle strength to be able to do it. So you get into this vicious cycle and you have to break it somehow. So I think there's also a role for TPN, like that
absolutely.
for the time, of course.
Why would you go straight to TPN and not try IMG first? Or if they have
So we do, I mean, these are in patients that have G-tubes, but they have a malabsorption problem. And there's only so much volume that you can get into them. Or oftentimes they'll have issues with gastroesophageal reflux because of their pulmonary problems. So they have really difficult time breathing, and their lungs are hyperexpanded as a result of air travel. So they're pressing down on their diaphragm, which presses down on their stomach. And so there's really, it's almost like having a gastric band. They have a smaller volume stomach because they just don't have enough room in there. And so when you try to put the volume in that you would like to be able to do in order to get the nutrition in that you really would like, they end up throwing it up.
Sure.
And then you get in a vicious cycle where they get an aversion